Welcome to Pediatric Case Review. Today we will explore developmental dysplasia of the hip in children, providing pediatricians and residents with an introductory overview of this important condition. This lecture will cover key aspects from clinical presentation to management through interactive case-based questions. Number: a 2-month-old female infant is brought for routine checkup. Which finding is most concerning for developmental dysplasia of the hip? A. Equal skin folds in both thighs. B. Limited hip abduction. C. Symmetric knee height when supine with hips flexed. D. Equal leg length. The correct answer is B. Limited hip abduction. This is one of the earliest and most sensitive clinical signs of developmental dysplasia of the hip. In a normal infant, the hips should abduct to at least 75 degrees. Asymmetric abduction between the two hips is particularly concerning and warrants further investigation. A 6-month-old with unilateral developmental dysplasia of the hip would most likely present with which of the following? A. Galizzi sign. B. Trendelenburg gait. C. Bilateral toe walking. D. Increased lumbar lordosis. The correct answer is A. Galizzi sign. This refers to apparent femur length discrepancy when the infant is placed supine with hips and knees flexed. One knee appears lower than the other, indicating unilateral hip dislocation. Trendelenburg gait would only be seen in walking children, not a 6-month-old infant. During examination of a 3-week-old female, which maneuver is most appropriate to assess for developmental dysplasia of the hip? A. Barlow test. B. Patrick's test. C. Thomas test. D. McMurray test. The correct answer is A. Barlow test. This maneuver detects an unstable hip that can be dislocated. It is performed with the hip flexed 90 degrees and adducted slightly, applying gentle posterior force. A positive test occurs when the femoral head dislocates posteriorly with a palpable clunk. The Barlow test is used together with the Ortolani test in routine screening. A positive Ortolani test indicates which of the following? A. Ability to dislocate a normally located hip. B. Reduction of a dislocated hip. C. Limited hip abduction. D. Tight hip adductors. The correct answer is B. Reduction of a dislocated hip. The Ortolani test produces a palpable clunk as the dislocated femoral head returns to the acetabulum. It is performed with the hip flexed 90 degrees, then gently abducted while lifting anteriorly. This test is most reliable in infants younger than 3 months. Remember that Barlow tests for dislocatability while Ortolani tests for reducibility. Which statement about the pathophysiology of developmental dysplasia of the hip is correct? A. It always involves complete hip dislocation at birth. B. It represents a spectrum from mild instability to complete dislocation. C. It affects males more commonly than females. D. It is typically bilateral in 90% of cases. The correct answer is B. Developmental dysplasia of the hip represents a spectrum from mild instability to subluxation to complete dislocation. Acetabular dysplasia may be present with varying degrees of femoral head coverage. DDH affects females more commonly than males with a ratio of approximately 6:1. It is typically unilateral in about 80% of cases with left hip predominance. Which of the following is not a recognized risk factor for developmental dysplasia of the hip? A. Firstborn female. B. Breech presentation. C. Prematurity. D. Family history. The correct answer is C. Prematurity. Contrary to what might be expected, prematurity is actually associated with a lower risk of developmental dysplasia of the hip. This is likely due to less time spent in a restrictive intrauterine position. The major risk factors include female sex, breech presentation, positive family history, and oligohydramnios. Other significant factors include firstborn status, torticollis, and foot deformities. Here's a case. A 3-month-old presents with limited hip abduction on examination. Which is the most appropriate initial imaging study? A. Plain radiograph. B. Ultrasound. C. CT scan. D. MRI. The correct answer is B. Ultrasound. Ultrasound is the gold standard imaging modality for infants younger than 6 months of age. It can visualize the largely cartilaginous structures not seen on radiographs. Ultrasound also allows dynamic assessment of hip stability and provides a radiation-free option for young infants. Plain radiographs have limited value before ossification of the femoral head. Which finding on hip ultrasound indicates developmental dysplasia of the hip in a 2-month-old? A. Alpha angle greater than 60 degrees. B. Alpha angle less than 50 degrees. C. Beta angle less than 55 degrees. D. Beta angle greater than 77 degrees. The correct answer is B. Alpha angle less than 50 degrees. The alpha angle measures bony acetabular coverage of the femoral head. A normal alpha angle is greater than 60 degrees, indicating a well-formed acetabular roof. Values between 50 and 59 degrees suggest borderline dysplasia, while values less than 50 degrees indicate definite dysplasia. The beta angle measures cartilaginous coverage and is complementary to the alpha angle assessment. A 3-week-old with positive Barlow and Ortolani tests should be managed with which of the following? A. Observation only. B. Pavlik harness. C. Immediate closed reduction and spica casting. D. Surgical open reduction. The correct answer is B. Pavlik harness. This dynamic splint is the first-line treatment for infants younger than 6 months with developmental dysplasia of the hip. It maintains the hip inflection and abduction, which is the position of stability. Success rates are 90 to 95% when treatment is initiated early. The harness requires regular follow-up, typically every 1 to 2 weeks initially, to ensure proper positioning and effectiveness. An 8-month-old with developmental dysplasia of the hip failed Pavlik harness treatment. The next appropriate step is which of the following? A. Continue Pavlik harness for 3 more months. B. Closed reduction with spica casting. C. Immediate open reduction. D. No treatment until walking age. The correct answer is B. Closed reduction with spica casting. This is the standard approach after Pavlik harness failure. It is usually performed under general anesthesia with arthrogram guidance to assess the quality of reduction. The spica cast is typically maintained for 3 to 4 months with periodic cast changes. Open reduction is generally reserved for cases where closed reduction fails or for older children. The most common complication of untreated developmental dysplasia of the hip in adolescents is which of the following? A. Avascular necrosis. B. Premature osteoarthritis. C. Recurrent dislocations. D. Growth arrest. The correct answer is B. Premature osteoarthritis. Untreated developmental dysplasia of the hip leads to abnormal joint mechanics and pressure distribution, resulting in early degenerative changes. This typically manifests in early adulthood, often in the 20s or 30s, with hip pain and limited mobility. Many of these patients ultimately require total hip replacement at a relatively young age, which underscores the importance of early detection and treatment. According to American Academy of Pediatrics guidelines, which infant does not require hip ultrasound screening? A. Female infant with positive family history. B. Male infant with normal hip examination. C. Female infant after breech delivery. D. Any infant with abnormal hip examination. The correct answer is B. Male infant with normal hip examination. The American Academy of Pediatrics recommends selective ultrasound screening rather than universal screening. Ultrasound is indicated for female infants with breech presentation, infants with positive family history of developmental dysplasia of the hip, and any infant with abnormal hip examination. All newborns should receive clinical hip examination, with periodic reassessment during well-child visits throughout the first year. A serious complication of developmental dysplasia of the hip treatment is which of the following? A. Avascular necrosis of the femoral head. B. Renal calculi. C. Respiratory distress. D. Cranial nerve palsy. The correct answer is A. Avascular necrosis of the femoral head. This is the most serious iatrogenic complication of developmental dysplasia of the hip treatment. It can result from excessive pressure or forced reduction causing vascular compromise to the femoral head. Risk factors include aggressive abduction and treatment initiated after 6 months of age. Avascular necrosis may cause long-term femoral head deformity and early-onset arthritis. For developmental dysplasia of the hip detected and treated before 6 months of age, which outcome is most likely? A. 95% require eventual surgical intervention. B. 85 to 95% have normal hip development. C. 50% develop avascular necrosis. D. All require limitation of physical activities. The correct answer is B. 85 to 95% have normal hip development. Early detection and treatment of developmental dysplasia of the hip, particularly before 6 months of age, has an excellent prognosis. Success rates are highest when treatment begins before 3 months of age. After 18 months, success rates decline significantly. Regular follow-up until skeletal maturity is recommended to ensure continued normal development. Thank you for watching our presentation on developmental dysplasia of the hip in children. Remember that early detection through routine screening is critical, and treatment strategy largely depends on the age at diagnosis. Timely intervention prevents long-term complications, and regular follow-up is essential. Please subscribe to Pediatric Case Review for more informative presentations, and leave any questions in the comments below. Your feedback helps us create better content for pediatric education.